So we are starting with our panel discussion that is based on diabetes crisis, India's diabetes crisis, which is huge right now, and uh, the most the most important and the significant aspect of this crisis today is how it is shifted not just from something like monitoring blood sugar, but something that involves multi organs, that involves heart, that involves kidney, and our entire metabolism. That is the topic of discussion today. And with me, I have eminent panelists here. We will be speaking about policy. We'll speak on how we can all try and overcome this crisis at a national level. So, welcome, panelists. Let us start from the very comprehensive and exhaustive study done by ICMR, the INDIAB study, which talks about diabetes across the nation, and it highlights how badly we are all in it, how so many of us have now been diagnosed with pre-diabetes, hypertension, and obesity. Sir, over to you. Please tell us about the study. How did it start, and then what are the findings?
Thank you so much. And first of all, at the outset, I would like to extend heartfelt thanks to the organizers for inviting me here and sharing the dais with my co-panelists. So when we say about, because I represent Indian Council of Medical Research, and that also one of the center which works on National Institute on Implementation Research in NCD. So this study was started in 2008 at a national level by the name of, we call it as India ICMR diabetes study, and we call it as INDIAB. So what exactly it says, first of all, we need to understand that it's a huge population level, it's a large survey study where the entire states were covered, but they were in a phase-wise manner. And the screening was done in all individuals who are more than 20 years of age. There was a sample size, and that was around 1,13,000 of individuals. But the data which was generated was quite surprising for all of us. We need to get into that is that if we ask what was the data which we have generated till date, it says that India currently is having diabetes of the level of 11%. But that ranges from states like Uttar Pradesh, where it is just 4 or 5%, to places like Goa, where it is 25%. And again, there was again an issue of, are we taking, just as you said, blood sugars, or are we taking something else? So we went beyond that. We have biomarkers. We have some of the lab values in that also. So hypercholesterolemia ranges up to 25%, and dyslipidemia ranges up to 81% in Indian population. Interestingly, there was also one thing which was done in this study by ICMR, and that was to look at the abdominal obesity. Because when we say obesity, it's just about BMI, but we know that when it comes to this cardiometabolic kidney problems, then it is more abdominal obesity. So though it is just 29% in India about the obesity, but it's 39% abdominal obesity. So we need to understand every 40 individuals out of 100 are having abdominal obesity and having all risk factors which can lead to multiple issues. So as I said, yes, it was an interesting study. It's started in 2008, still going on, though it finishes in 2024, but the data analysis is still going on. And it tells about even pre-diabetes. That is also very important. So as I said, 11%, but 15% are pre-diabetic. So sometimes we feel that, as we say in epidemiology, there is always a plateau. If some disease is growing up, it will come down. But this is not going to happen because in diabetes, though we are 11%, but these pre-diabetic are going to change very rapidly. So yes, very interesting figures, but at the same time, giving us data which is showing that India definitely is on a way of having a big minister of NCD, which Minister of State Anupriya Patel mentioned.
Yes, and also there are some startling statistics from the NFHS 5 survey also that shows 1/4 of Indians are overweight or obese, while 40% of women have abdominal obesity, which is huge. So please throw a light on the survey and how we can really, what can we do about it? Thank you.
Sir has spoken about ICMR in the study which
And there is another study initiated by the Government of India, National Family Health Survey, NFHS. And these NFHS surveys were started from the 1990s. So first, these surveys didn't include the prevalence of diabetes because they didn't check blood glucose. From NFHS 4, which was conducted in 2015 to 2017, and then we have NFHS 5, which is 2019 to 21. So now we have two NFHS where blood glucose was also measured with the glucometer. And there is a large number of population covered. The total population covered was 7.5 lakhs in NFHS 4 and 7.5 lakh in NFHS 5. All 28 states, all 7 union territories, all districts were represented. And this data has shown that our prevalence of diabetes was 3.5% in NFHS 4. Now this has increased from 3.5 to 3.9%, which doesn't look large increase, but there's a 14% increase, and this is happening in a large sample data of 7.5 lakh of people. And when we analyze this data, where maximum increase has come, we can most of the time we think that maximum increase has come where people are obese or people are becoming obese. Yes, this is true. Even though BMI changes in the normal range, but there is an increase in that. And maximum increase has happened in poorest and poor segment. So there are 5 socioeconomic categories: poorest, poor, middle, rich, and richest. So maximum increase is happening in poorest and poor. Maximum increase is happening in the rural area, and maximum increase is happening in those who have BMI in the normal range. The amount of increase which is happening in obesity is also there, but more increase is happening in those who are having normal BMI, because there is increase in the BMI, although it still remains within normal range, but there is increase in that. So that is something which is very important for us to understand, because previously diabetes were increasing in the rural and urban areas. Now we have a rapid increase of diabetes in rural areas as well. We may think that rural areas do not have that much vehicular facility, do not have that much food stalls, but there is rapid change in the lifestyle of the rural areas as well, and there is increase in shifting in the BMI of the higher side, and this increase in BMI is resulting in the increase in prevalence of diabetes. And unfortunately, this is happening in those areas where our health infrastructure facilities are not that robust. We do not have a dietitian there, we do not have a trained physician to treat them, and where we are seeing the maximum impact. So we need to take steps to prevent this migration in BMI, and which is resulting in increase in the diabetes. So this is NFHS 5 data. This is up to 2021, and the next NFHS may show more increase in the coming from the other rural areas.
Yeah, that's very concerning that the largest numbers are from the rural areas, which was not like this many years back. So that brings me also to another very important aspect, or sir, maybe you could tell us on how this these numbers show not only on blood sugar, but as we said, on the entire CKM paradigm, where all the multi-organs are involved. There is heart, there's kidney, and there's the entire metabolism. That, as well as please also throw a light on how, there are these GLP medicines, how they help in addressing this issue, please.
Yeah. Actually, diabetes and obesity, these are not simple diseases. Actually, they are associated with multiple problems. They are associated with cholesterol, lipid irregularity, hypertension. They are associated with fatty liver, which can ultimately lead to cirrhosis. They can lead to chronic kidney disease, CKD. They can lead to cerebrovascular accidents, lead to stroke. They can lead to your coronary atherosclerosis, heart attack. So, one should take them as a holistic approach towards the management of diabetes and obesity. And as already been discussed, numbers are huge. About 10%, more than 10% of adult population is suffering from diabetes and obesity. So we have to give a holistic approach towards the management of these patients. And because these are the lifestyle diseases, so we should have lifestyle modification in our life. We should have good, healthy life, healthy diet, as well as good exercise, mental relaxation, and avoidance of other risk factors. Because these patients already have multiple risk factors. So if anybody is smoking or taking heavy alcohol, all these things should be avoided by these, because ultimately it will compound the problem. And as far as the management is concerned, the bottom line is control of blood sugar. For diabetic, if you are not able to control the blood sugar, everything is waste. So you have to achieve your HbA1c target. And the second aim of management of these patients is avoiding the complication. We know that the prevention of complication is better than the treatment of the complication, because the treatment will be very difficult and very expensive. So we have to pick up those patients who are going to develop complications. So we should use medication which can be useful not only in the control of the diabetes and obesity, but also can prevent the development of complications. So one of the agents is GLP-1 agonist that is now available in our country also. And one of the very good agent is semaglutide, because now we have good evidence from the clinical trials which have shown that GLP-1 agonist semaglutide is not only controls diabetes and obesity, it prevents around 15 to 20% reduction in the cardiovascular event, CKD event, and fatty liver, peripheral vascular event. So these agents are really useful, now available, and can be used for these patients.
Especially those with cardiac issues?
Yeah.
Okay. Right. That also, brings us to another very important aspect of childhood obesity. So, sir, at AIIMS, tell us about the figures in childhood obesity, maybe in the past year, in your own observation. Have these numbers increased? And if yes, then what do they come to you with? What are the symptoms that they come to you with? What are the diagnoses made?
Yeah. Not only apart from hospital-based prevalence of childhood obesity, we have gone to Delhi schools and we have carried out the study. And these studies were carried out with a huge number, 1 lakh population of school-going age children. So initial studies we did in 2009 and 10, and we found that 5% of them are prevalence of obesity and 15% is overweight. So combined, approximately 20%. These are the fee-paying schools of Delhi, which also included the government schools. When we compared the prevalence of childhood obesity in government school versus the fee-paying school, or what we consider the private schools, there was a huge difference. Childhood obesity in government schools was less than 1%. And the fee-paying school, the obesity was 20 to 25%. So there is a huge difference, and probably maybe difference of socio-economic strata or facilities available or avenues available for eating foods. These might be difference, which explain that there is a huge gap between government and private schools. Then after 2015, we again repeated the same school. We selected same schools of Delhi, although the children population they have moved, the new population has come. So, but on an average, the childhood obesity remained less than 1% in the government schools, but there is a phenomenal increase in childhood obesity in the fee-paying schools. 5% has increased to 6.7%. So there is a shift in obesity, and most of these overweight are turned into the obesity. Then we went back to our original cohort of data, and then we analyzed where these children are, who were analyzed in 2009 and 10. 80% of them has converted into obese adult. So if we are seeing a child with childhood obesity, there are 80% chance we will end up in obese adult, and many of these obese adults are having the complications of obesity, maybe their impairment of blood glucose, impairment of blood pressure, there are many other complications. So it's not a simple problem. Childhood obesity has its own problem, and unless we go at the level of school and start our preventive measure, which may be like introducing chapters on the healthy nutrition, providing them more facilities for playground, like providing a playground and teachers who can guide them, and not opening computer lab and all these things during the playing hours and dedicated 1 hour playing hour. And this again shown clearly from a study has come from Brazil, where they have implemented these strategies for 5 years and clearly shown that childhood obesity has decreased in those schools. Similar strategies they can also adopt in our country, our schools. What we are seeing childhood obesity in management in AIIMS Delhi is it's only a small proportion and only those who are extreme form of obesity. We do not see overweight, why overweight should come to AIIMS, but we are seeing the extreme form of obesity where BMI crosses 30, 35 or 40. They are coming for management, which is a small proportion, and when we analyze, we found that 60% of them will have at least either impairment of blood glucose or impairment of lipid profile or impairment of their blood pressure. So these risk factors are there and they are progressively increasing. We need to tackle childhood obesity problems. At least we can make them not to turn into obese adults.
Right. At least 60%. That's a very, very huge number. So, sir, tell us about how ICMR is also, trying to focus in terms of policy making on this aspect. How diabetes, obesity, and this is all interlinked. It's not in silos, right? It's a complete profile. It's complete multi-organ. How you need to address well-being. So, are you looking at a CKM lens when it comes to tackling these issues?
Thank you for the question. I think as I represent currently ICMR, which is the research body of Government of India, besides providing the service delivery to the people of this country. So what ICMR is currently doing is it's a kind of a hand-holding or kind of a support to the health system. And if you ask us that where the problem should be identified, it should be identified in the very early phase, as every one of us will say. In the morning also, it's about primary or primordial prevention. And the screening should start at the very Ayushman level. So what ICMR and NHSRC and Government of India is doing, these 1.5 lakh Ayushman Mandir, where these community health officers are being recruited, they have this, what we call it as CPAC forms, community-based assessment checklists. And these CPAC forms are digitalized. There is, CHO is supposed to screen individuals who are more than 20 years of age for all these risk factors. So, how, what for example, there is a screen positive, can CHO be empowered to deliver medicines? No, because the job is of a doctor. And what a kind of a continuum of care, a referral mechanism that a doctor, maybe at PHC and CHC, should write a medicine. Now, when a PHC, CHC doctor is writing a medicine, as you say, it's a CKM approach. So, would he or she be so much empowered that he or she can write a medicine? Yet again, ICMR is working on that. And yesterday only, we had released, we have our second ICMR-DHR summit, where Honorable Minister has released that standard flow of management or standard treatment guidelines schedules which are being delivered to the CHC and PHCs for those medical doctors, as well as some of the ways in which CHOs can also work. I'll give you a very quick example. Like, for example, you're saying, what about CKM angle in diabetes? We'll say only ABCD approach. That is only to be told to a person who's coming for counseling and behavioral changes in that health and wellness centers. And when I say ABCD, so the one thing is A stands for HbA1c less than 7. So one has to be very clear that the glycosylated hemoglobin should be less than 7. That is something which he or she needs to remember. We say B stands for blood pressure control. So always less than 140 by 80. It should always be less than that millimeters of mercury. When we say C stands for cholesterol and LDL, which should always be in the admissible limits, which is being there by the clinicians and laboratory people. And when I say D, it stands for discipline. So these small measures, and when we say discipline, it's about what Sir was saying about all those behavioral changes, lifestyle changes, diet, physical activity. So these small messages, they've been, been made, developed, by the ministry. ICMR, check that in different trial mode or maybe in that pragmatic trials. They generate evidence and then they support Government of India.
Such similar have been taken in terms of cardiac issues as well. So what do you think? And also tell us, if you could explain to us the actual, in very layman terms, the connect between diabetes, obesity and heart. How does one lead to the other and what are the repercussions?
Actually, diabetes and obesity, they all associated with hypertension and are associated with dyslipidemia. And whenever there is a multiple risk factors, that ultimately lead to atherosclerotic disease, that is coronary artery disease and cerebrovascular disease. So patient will started having coronary artery disease, that will lead to the involvement of the heart, and patient can develop maybe heart attack. And secondly, it involves the heart muscles and can lead to heart failure. Heart failure and ultimately will lead to problem to the kidney. Whenever there is any problem in the heart is always associated with kidney problem, and kidney problem itself can lead to the heart problem. So there is a connect between the heart and kidney. And secondly, because the atherosclerotic diseases can be there in the brain circulation also, so that will lead to the your stroke. So they are all interrelated. So that's why we should have a holistic approach to diagnose or to pick up those patients early in the development of complication. Suppose any patient with diabetes and this obesity coming to any physician, he should investigate those patients for any silent involvement in the heart, silent involvement in the kidney, silent involvement in the brain circulation. So if we can pick up those patients early before development of full-fledged complication, we can have a good outcome.
So when you are dealing with issues of obesity and diabetes, do you also advise patients to also at the same time, you make sure that their heart is also in good shape?
Yes.
And now with these evolving pharmacotherapies, do they help in addressing this?
Yes. Actually, all these patients should go for lipid profile, for carotid vascular Doppler and kidney ultrasound, urine examination. So we can detect those patients, and we have good medicine in the form of statins, which is now freely available, as SGLT2 inhibitor and now GLP-1 agonist, and we have aspirin and other agents. So they are very, very effective agents and can prevent those complications.
Next, I want to talk about something very, very important and, which we all hear of is gestational diabetes that most often converts to pre-diabetes and then full-blown diabetes. So, sir, tell me why, we are unable to address this issue at its core. Why does gestational diabetes not stop there for most of us, most of women in India?
Gestational diabetes is nothing different. It's a type 2 diabetes which is in our population. If our population prevalence of diabetes increases, definitely gestational diabetes will increase, because from these females, some of them will become pregnant, so they have higher chances of diabetes detection. So the focus has shifted from gestational diabetes to type 2 diabetes in pregnancy, which is most of the time we are seeing is if you check blood glucose in first trimester, it comes very high, which is difficult to explain from the point of view of gestational diabetes, because traditional teaching is for gestational diabetes to check blood glucose at 24 to 30 But now, because of these facts, Government of India has changed strategies, some new strategy devised by the Government of India, which is applicable to all states. As soon as pregnancy comes in contact with physician, check blood, check diabetes, whether diabetes is there or not. And diabetes even in pregnancy test becomes positive at 3 weeks or 4 weeks, and if we check, diabetes is there. So diagnosing diabetes is one of the easiest part of gestational diabetes. So diabetes with pregnancy, we can diagnose, glucometers can be sent to our PFCs everywhere. We can diagnose gestational diabetes. Do we have that much manpower to treat the gestational diabetes? It's a little bit different from the type 2 diabetes, where we cannot use most of the drugs, or we can say all drugs one drug which is metformin, all other drugs do not have safety to be used. So now, once diabetes is there, we do for lifestyle management for 2 weeks, still blood glucose is not controlled, we have to shift to insulin, which is little bit tricky and difficult, and facilities for self-injections of insulin and then providing insulin to them, keeping insulin at low temperature is little bit cumbersome. So until unless we tackle diabetes in our general population, gestational diabetes or diabetes with pregnancy is likely to increase, which is most difficult part of diabetes to be controlled. And here we do not have one life, we have two lives at risk. If baby is exposed to the high blood glucose, future chances of his developing chronic disease increases. So somebody who is not born and even before birth, he has develops high risk of having future complications. So that is one of the most important part, and we need to address that. How do we decrease obesity in our society, which should reflect in decreasing prevalence of diabetes, and prevalence of diabetes decreases at the same time. This will also show a decrease in the gestational diabetes or type 2 diabetes with pregnancy.
Right. And when it comes to addressing that part, so I would like you to take it up from here. Tell us what, according to you, should be the roadmap going forward when it comes to addressing this particular aspect through the CKM lens. What should India be looking at? Maybe if you could give us a yeah.
Yeah, so thank you so much again. As I said that, Government of India is already working on this. And as I said that now, even this term multimorbidity is now no longer used in medical schools. Now we have started calling it that multiple long-term conditions. We call it as MLCs. Now we have traveled that path from multimorbidity to MLCs. Now, what government is doing currently and what ICMR is supporting is, again, to make that system of that protocol, which are to be started from the very beginning, from the lowest part of the health system delivery, which now is ICMR-NIIRNCD, or what the minister was saying in the morning, and then continuum of care. Now, one thing which I would like to tell to the House is that, as every one of us will say, that it is an era of digital health. It is an era where POCTs are to be there. So now, ICMR is also working in the area of POCTs. These smart devices, how to validate it. As we say, AI says garbage in, garbage out. So if we have good data, we call it as data-driven monitoring systems. So we are maintaining that, good registry, quality registers. It's not just the diagnosis, it's also about the management and the compliance, how to check it. Because it's not a one-time, every one of us is saying, it's a continuum of care, how to ensure that. So that digitalization, that POCTs, that this data-driven monitoring, how to do it in government, and now currently this through different solutions. MedTech is again one of the program of ICMR, where the Indian innovators, right from IITs to business partners and ICMR and ministry, they are working together to bring it to that level. So as you said that, if we improve the diagnostic skills, if we increase the reach, as in the morning, everyone, the minister said it's not just affordability, accessibility, it's quality as well as equity. So we need to remember that it should reach to the rural areas also. So a roadmap is ready, and ICMR, I think they are working with the health system delivery model, and we are very hopeful that with these new innovations, the kind of the CKM lens will help us to manage the issue of diabetes.
Right. So now, maybe we could all three of you could tell us 3 ways in which we all can, manage our own health in terms of diabetes, obesity, and very practical ways, everyday ways, maybe in the way we can do it. Let's start from you, sir.
The best would be to address our weight, because obesity is prerequisite for all these type of diabetes, CAD, and the basic mechanism is insulin resistance, which is driving all these complication lifestyle diseases. So we need to address the insulin resistance, and best way to address the insulin resistance is to increase our physical activity. At the same time, to decrease our calorie content, and especially the fat portion of the calories should be reduced. If we can start these two ways, we can tackle obesity, and if we tackle obesity, rest of the diseases will come down.
Yeah, I think I echo with what Sir says. The only thing is that let's have some quick solutions, quick tests on us. And I say in my medical school when I was doing AIIMS as professor, that we can do one thing at least, that we know our height. And if we know our height in centimeters, we need to minus 100 only. And that is our ideal weight. We call it as Broca's index. At least we can do that to us and to give us a value. If I'm 164 centimeters or 170 centimeters minus 170 kg, I can't be beyond that. Even plus 5 kg of weight, as I say, is a big risk factor for getting me into a cardiovascular risk or a kidney risk. So at least do that to us, and that would really help us to control of the risk.
I think it is well said that it's a lifestyle problem. So lifestyle modification in the form of diet, healthy diet, and regular exercise is must. I will just like to add one more thing, that the screen time. The screen time has increased like anything, and it is turned out to be one of the major risk factors for CKM later on. And so we should restrict the screen time. If you see the family members sitting on the dining table and everybody is screening, looking on the screen, they are not interacting. And now we have executives, they are working from home and they are having a lot of screen time, and they actually take a lot of snacks during that screen time. So we should restrict screen time to minimal. That will also improve our health.